So good morning, good afternoon, good evening to everyone around the world. And welcome to the ACNS YNS webinars. Today, our chair is Professor Takayuki Ishikawa, who is the consultant neurosurgeon of the Japanese Red Cross Aichi Medical Center in Nagoya Daini Hospital in Nagoya, in Japan. And we have two speakers of today. The first speaker is Professor Yudo Ishii, who is Associate Professor of the Department of Neurosurgery of the GK University School of Medicine in Tokyo, Japan. His topic is Refined Surgical Strategy for Endoscopic and Endonasal Surgery for Pituitary Adenomas. Our second speaker is Dr. Volodymyr who is a neurosurgeon in Whitby in UK. His topic is 360 degree stabilization for cervical spinal fractures at C3 to Th1 level. For our discussion today, we have Professor Hiroki Morisako, who is the specially appointed Associate Professor of the Department of Neurosurgery of Graduate School of Medicine in Osaka Metropolitan University in Osaka, in Japan. Our second discussant is Dr. Petru, who is the Assistant Professor of Neurosurgery of the Universitas Pelita Happening in Saloham Hospitals in Nippo Village in Indonesia. At the end, Professor Ishikawa, our chair, will also give a one-point essence of the wet field surgery. To moderate the section, we have three SEM, Dr. Biswa, and Dr. Hui Feng. And without further delay, shall I pass the podium to our chair, Professor Ishikawa, to chair our webinar today. Thank you, Professor Ishikawa.
Thank you. Thank you for introducing me, and it is a great honor for me to serve as chair this ACNS YNS webinar. I'd like to express my sincere gratitude to the patron Yoko Kato and the member of the ACNS YNS. Today, we invite two distinguished speakers. The first speaker is Dr. Ishii from GK University in Japan. He's very famous endoscopic and nasal skull-based surgery in Japan. His topic is pituitary surgery. Then Dr. Ishii, please start your lecture.
Okay, hi. Good evening, everyone. So it's my great honor to be here, and just a moment. And my topic's about pituitary adenoma. So I will talk about the endoscopic endonasal surgery for pituitary adenomas. Endoscopic endonasal surgery is mainly used for midline skull-based lesions. Its key advantage is minimal invasiveness and early access to the tumor origin. However, the approach has limitations, including a deep and narrow surgical corridor and reduced depth perception due to the two-dimensional view. Therefore, it requires advanced technical skills and precise anatomical knowledges. When removing tumors, lesions with a clear boundary, such as craniopharyngiomas, can be resected safely and reliably by following the natural dissection plane and anatomical landmarks. In contrast, pituitary adenomas lack a true capsule. Therefore, most surgeons perform internal debulking using suction and curettes. Because the tumor is removed from the inside, there is a risk of leaving residual tumor tissue due to blinding spot or incomplete visualization. This residual tumor can sometimes lead to postoperative hemorrhages. Recently, extracapsular resection using shoot capsule has been attracting attention in removing pituitary adenomas. The advantage is the usage as a surgical boundary. It improves the surgical cure rate in non-functioning adenomas. But there are some risks of CSF leakage and pituitary dysfunctions, and it is difficult to remove the shoot capsule safely in tumors with suprasellar extension. Pathologically, the shoot capsule is composed of normal pituitary gland and connective tissue, and the pituitary gland is structured in layer like onion. Therefore, if we remove the shoot capsule thickly into the pituitary gland, it causes pituitary dysfunction or intraoperative CSF leakage. So we should find an appropriate layer in making an extracapsular resection. In this presentation, I will talk about safe and reliable resection of pituitary adenomas in endoscopic endonasal surgery. I will also discuss which types of tumor are suitable for the extracapsular resection and how to find the appropriate layer, in other words, through shoot capsule. How to find a shoot capsule? In most of cases, the capsule is found on the side of the normal pituitary gland. In this case, firstly, my colleague is trying to find the capsule using suction and forceps, but he cannot find it. Next, the supervisor takes over and continues surgery. The capsule is found immediately. Keeping slight tension by forceps, the boundary is divided by the suction tip. I will show some cases of pituitary adenoma. First case is a pituitary adenoma with mild suprasellar extension. Most of them are removed safely with extracapsular techniques. The cellar floor is opened with chisel and preserved for closure. The dura is cut in H shape, and the pituitary gland is found at the left side. The boundary between tumor and pituitary gland is found, grasping the shoot capsule, and is divided by suction tip. Releasing attachments, the suprasellar part is naturally pushed down by intracranial pressure. Then the tumor and its shoot capsule are totally removed. The normal pituitary gland can be seen on the left side, and the medial wall of the cavernous sinus on the right. Finally, the cellar is closed completely. Tumor is totally removed without any complications. This case is also a pituitary adenoma with suprasellar extension. Sometimes we meet much bleeding during resection, but using the extracapsular technique, we don't get lost the way because of following the boundary. After internal decompression, the shoot capsule is identified on the right side. By applying gentle traction to the shoot capsule, dissection along the plane between the shoot capsule and the normal gland is performed with the suction tip. Despite significant bleeding, following this boundary allows progression towards the suprasellar lesions. With further dissection, the suprasellar component is delivered downward by intracranial pressure, enabling total resection under direct visualization. Diaphragm and the suprasellar membrane are bulged down, but there is no obvious CSF leakage. Complete dural closure is achieved with 2 sutures, followed by rigid reconstruction using the replaced cellar floor bone. In postoperative MRI, there are small hemorrhages, but no residuals. This case, a pituitary adenoma with irregular shape. Because the tumor extends into the subarachnoid space, there is a possibility of adhesion to intracranial vessels and nerves. Therefore, when resecting the protruding portion, it is important not to remove the capsule. The cella and anterior skull base are opened, and the intracellular component of the tumor is removed first. The tumor is extremely soft and can be easily removed. As the removal proceeds, structures suggestive of normal pituitary gland can be identified. On the left side, the stretched normal pituitary gland descends, so it is gently compressed with Sargcell, while the supracellular tumor removal continues. After removal, the anteriorly extending portion, together with the arachnoid membrane, is pushed forward. Therefore, it is removed while leaving the capsule intact. By holding the arachnoid down with Sargcell, the shoot capsule of the tumor can be identified on the left side in the cella. Following this shoot capsule plane, dissection proceeds, and the normal pituitary gland is confirmed posteriorly. Section of the intracellular shoot capsule continues upward along this boundary, revealing a protruding component in the right superior region. Cut the anterior skull base dura. This protruded portion is removed by intracapsular suction, preserving the capsule. The tumor is a little bit hard, but mostly removed safely. And the tumor are removed. Hemostasis of the resection cavity is achieved with Sargcell. The dural defect is closed with a fasciolata patch using sutures, and the cellar floor and skull base are reconstructed and covered entirely with a local flap. The postoperative MRI shows complete tumor removal with preservation of the normal pituitary gland. This case is a large pituitary adenoma, extends anteriorly and involves arteries. We perform an extended endonasal surgery with opening the anterior skull base. After wide opening of the sphenoid sinus, the cella is opened with chisel and is preserved for closure. The tumor is very soft, and for removing anterior extension part directly, anterior skull base is opened for extended endonasal surgery. The cella part of tumor is removing by suction. Pituitary gland and cella dorsum are identified. Then anterior part is removed. The optic chiasm and ACA are exposed. Removing by suction, gradually exposing ACA, paying attention not to injure small arteries. Most of tumor is removed by suction irrigation. Hemostasis is made. The dura is closed by fascia patchwork suturing. A fasciolata larger than the dural defect is laid in the subdural space and sutured with dura like a patchwork. The first suture is always made at the anterior end because this part is most difficult to suture. Next, the posterior part is sutured for pitching fascia tightly. The remaining portions are then sutured in a diagonal fashion, securing the fascia under appropriate tension. The dura is closed tightly. Another fascia only. The anterior skull base is reconstructed by nasal cartilage, and the cella is closed by the preserved floor bone. A local mucosal flap is applied. Postoperative MRI shows small residuals around ACA, but there are no change for 5 years. How about this giant tumor? Tumor is lobular shape and extends laterally, located behind the MCA. It seems like to be removed by extended endonasal approach, so we performed extended endoscopic endonasal surgery. Tumor is very soft, easily removed by suction. First, the center part of tumor is removed for making space. Using this space, another part is removed subcapsularly. Posterior protrusion is removed with double suction and irrigation. Upper part is removed, leaving the capsule behind. Involved arteries are exposed. Lateral protrusion is also removed, and the outer membrane is flipped out. After removal, fluorosil is applied for hemostasis. Most of tumor is removed. Tumor was subtotally removed, but there was subarachnoid hemorrhage postoperatively. The patient needed additional treatment because of MCA vasospasm. In such tumor with lateral extension, the combined surgery with transcranial and endonasal is safer. This case is a large pituitary adenoma. Tumor extends into the cavernous sinus and protrudes to the subarachnoid space. To reach the protruded part in this case, cavernous ICA and oculomotor foramen will be good landmarks. So we can remove this tumor with pure endoscopic endonasal approach. The sphenoid sinus is widely opened. The tumor is very soft and can be easily removed by suction. However, the superior aspect of the tumor cannot be reached initially. By opening the anterior skull base and approaching from above, the suprasellar component is gently pulled downward using two suction and safely removed without the capsule. The cavernous portion of the tumor is then resected and the ICA is exposed. The cavernous component located posterior to the ICA is removed by suction with gradual exposure of the cavernous sinus wall. Tumor extending lateral to the ICA is also resected. The portion the protruded component within the cavernous sinus behind ICA is removed through the oculomotor foramen. And near total tumor removal is achieved. The dura is closed with suturing, and reconstruction is completed using a nonceptal flap. The tumor is nearly totally removed. This is a summary slide. To remove pituitary adenomas safely and reliably, the resection method should be changed depending on the shape of the tumor. Round shape can be removed by extracapsular technique. using shield capsule as a surgical boundary, tumor can be removed safely and reliably. Lobular shape should be removed by subcapsular technique, leaving capsule for preserving surroundings. Giant tumor and tumor with lateral extension should be removed by combined surgery. This is my SCAR-based team and trainee from other countries. Thank you for your kind attention.
Thank you for grateful lecture, including beautiful operative video.
Thank you.
It's really impressive technique. So we are starting discussions. First, I'd like to hear the comment from Dr. Morisako. Please, Dr. Morisako.
Yes. So thank you, Professor Ishii. So
Thank you.
so nicely, so you are the sort of lecture based on your many the experience. So I have some of the question. So one is so that sometimes the shield capsule is not so clear, such as the case of the cystic pituitary adenoma.
Oh,
Shield capsule very thin. So how do you think in the case of the cystic, the pituitary adenoma?
Maybe in the cystic cases, we can find the pituitary shield capsule every time because there are some inflammation around the tumor and it helps to make the capsule. So that's why we can find the capsule. But of course, the tumor is developed if you open the tumor, so that's why you cannot find it easily. But
sometimes very thin, and so the arachnoid is so the very close to the shield capsule. So sometimes I'm afraid of the CF leakage during the tumor removal. So
But maybe if the tumor has cyst, there are some adhesion between the capsule and arachnoid membrane. So I will leave the part of there. So it's
okay,
very
thank you for your comments. And so sometimes I usually use the surgical cotton is very useful to the peeling off the shield capsule from the normal pituitary gland. So that make the border sometimes very easy. So how do you think some the cotton noise by using during the peeling of the shield capsule?
So because I always do the capsule dissection by direct seeing, so if we use the cottonoid, we cannot see the margin directly. So I don't like that. So
usually you use the double suction or the
yes, that's right.
Or the okay, forceps. Okay, thank you for your comment.
Thank you so much.
So, thank you. Next, do you have any questions or comments? Dr. Petra Vajupramano. Dr. Vajupramano is here?
No, he's not here. He's in an operation.
So I have two questions, Dr. Ishii. You close dura, you using fascia lata always, or do you use fat graft or Duragen or collagen sponge like this?
So in case of the surgery, only opening the cera, we don't use fascia lata, just close the dura directly. And if we do the extended approach like anterior skull base opening, we always use the fascia lata. And the Duragen, some collagen material, I don't use that because it's not sure, because during operation we cannot stop the CSF leak completely. So I always use the certain method like fascia lata. Okay.
Thank you. Yes. And next is you use local mucosa, sphenoidal mucosa. Do you use septal flap?
Of course, some case we use the septal flap, but we always close the dura tightly so that the local flap or mucosal flap is for preventing CSF leakage. So it helps promote healing of the opening area. So that's for the mucosa is for the healing and preventing infection, not for preventing CSF leakage. So we think so. Sorry.
Thank you. And Dr. Ben, do the question from webinar audience?
Yes. Yeah, I can ask some questions to to Professor Yudo. Yeah, I
Okay.
want to ask about I saw your video. You have different surgical instruments to do the capsular dissection. Do you use the two suction
Yes.
method always, or do you use a dissector? And for the suction, how large is the suction for the two suckers?
Oh, so the suction tip is 2 millimeter or 3 millimeter, so not so large. And the suction tip is blunt, so not so sharp. And I don't use dissector because if we use the dissector, we may enter the normal pituitary gland outside of the shoot capsule. So I don't like that. So I always use the suction tip for dissecting the brain.
So how large is the suction force?
Force,
Suction force.
action force. Force means
Like
Power of suction.
power. Yes.
power. Oh, I always control the suction power. Yeah, because our suction has a nose for controlling the power. So I always control the power like a microscopic surgery. Okay,
Okay.
thank you.
Thank you. Thank you.
If I may ask one question to Prof.
Okay.
Ishii Sensei. Two questions. One is that even after removing large tumors, I saw you did not fill the dead space with fat graft.
Yeah,
Which is
yeah.
very surprising because that is a standard procedure employed right across the world. And second question is, what instrument do you use for suturing? Is it a single shaft instrument like Morisako Sensei uses the Jester needle holder? What about you?
So about the removal cavity. So of course, I use the part fragment when we see the minor CSF leakage. But in case of opening the anterior skull base and extend into the subarachnoid space, I don't use the fat because if I use the fat, I have to put the fat in the subarachnoid space. I don't like that, so I just close the dura tightly. So, and suturing instrument is originally for minimally invasive cardiac surgery. It's a single shaft shape and very fine and good instrument. So
Which company is it?
oh, that's a Geister
Oh,
German company.
same
Yeah.
as Morisago sensei uses.
Yes,
Yeah,
that's
same. Yeah.
Okay,
Many
understood.
Japanese surgeons usually use that instrument.
Thank you very much. Yes, Volodymyr has raised a hand.
Yeah. Thank you, Professor, for a nice lecture. I would like to ask some question about if you have complications CSF leakage. What you do revision surgery, or you or you sometimes or you do in your practice lumbar drainage, or you use strict bed rest. What are your opinions about this complication?
So in case of CSF leakage, I choose the bed rest first, but if not stop, then we choose the second surgery. But of course, we have no CSF leakage for many years, so I don't care about that. Sorry.
Thank you.
I think we have lost Ben.
Yeah.
So, Prof. Taka?
There are maybe many points for discussion, but now we are next session. We're going to the next session. Our second speaker is Dr. Volodymyr Yaroslavskyi from Ukraine. Doctor, please begin your presentation.
Okay, need to. Okay, 1 second, please. You see or no? No?
No.
No.
Not yet.
Second. Share. Now?
Okay.
Yes.
We can see.
Okay. 1 second.
Please, you are in the presentation mode, and then.
You see now my presentation?
Yes, again in the presentation mode itself.
Yeah.
No, you are in the
change the
presentation mode.
Okay,
Yes.
1 second. Now?
Okay.
Yes.
Okay. Okay. My presentation today, it's my topic is 360-degree stabilization for cervical spine fracture at C3 Th1 level. Let me introduce first my. I'm sorry. Okay, let me introduce. First of all, I'm Dr. Volodymyr Yaroslavskyi from Ukraine. My city Rivne. It's you can see in the map the red. My region where I live and where I work. Okay, I have been working in neurosurgery for 10 years and work in such wonderful team. It's my team, it's my colleagues, and it's my department in Ukraine. You can see in the photo. Primary mechanism of cervical spine trauma, it's shallow water diving, road traffic accident, fall from the height, and sport-related injuries. Clear indication for circumference stabilization for our recommendation. It's AO type C injuries, a fracture dislocation C3, C7, failure of anterior or posterior fixation, posterior ligamentous complex rupture with instability, multi-column, more two-column involved, and significant kyphotic collapse on instability reduction. I use for classification subaxial injury classification system. It's our classification, and I consider for 260-degree stabilization for B2 or type C. For neurological deficit, I classify for Asia classification. Asia classification, we can use Asia for neurological deficit. What I doing for the planning, how I prepare to the planning operation. I prepare to CT scan. I saw the bony anatomy. What I decided. What pedicle diameter, optical entry point, and anatomical variation, and angio-CT. When about how it's vertebral artery going. Yeah, for skin incision, I sometimes use incision for the medial parts of sternocleidomastoideus, and sometimes it's a transversal skin incision. It depends what level I decided to operation. It's when I go anterior for the anterior approach. For posterior approach, I use prone position and use transversal skin incision. How you can see in the photo, and about skin incision, it dependent what level I decided to operate. What technique I use for screw? For my department, we consider for two technique Magyar, Camille, and modifical technique Anderson. You can see in the photo. For me, I use modifical Camille because it's more easier put to the screw on the lateral mass. Also, you can see in the photo, and it's most safety put because you don't injure a vertebral artery if you put the screw the lateral mass. And sometimes when we have a difficult fracture for the lateral mass, sometimes we use the pedicle fixation. You can see in the photo how it's I decided to do, but need to be very carefully because you can injure a spinal cord or vertebral artery. It's very important. How it's fixation for how I do fixation for vertebra C7 and Th1. It's very important too because this vertebra, how it's another anatomy. I preoperative planning the entry how I put the entry point orientation in both sagittal and transversal planning, optimal screw diameter, and anatomical variation. In C7 and TH1, I planning transpedicular fixation, and it's a more harder fixation for this vertebra. Okay. For anterior cervical approach for fixation, I use cage or sometimes bone and anterior plate and put screw. For posterior, I used only screw. My case presentation, one case presentation, I would like to tell it's 49 years old man involved car accident, where you can see in CT C5, C7 injury, spine classification type C, and Asia neurological deficit is Asia D. For video CT, you can see It's a very difficult fracture. You can see the facet joint dislocation. Okay, and in this case, I'm planning to do 360 stabilization. It's a CT after stabilization, after operation. It's my first case for operation. I do C3, C6, lateral mass screw, and go anteriorly, put the bone and put the anterior plate with the screw C5, C7. Yes, and axial, how it's put and screw, it's C3 you can see, and C7 and anterior plate. How it's looking in 3D, you can see a screw and anterior plate. It's look all very good stability, and patient is discharged without a neurological deficit from department. The second case, it's 45 years old man involved car accident. You can see C5, C6 injury, our spine classification type C, ASIA D, CT after operation. You can see, I decided to do 360 stabilization. I put screw lateral mass C5, C7 for posterior, and after in anterior I put the cage C5, C7. I put anterior plate and the screw on the body. You can see in the axial C5 and C7, C6. I'm sorry. Yeah. And put anterior plate. For 3D, you can see and look very stability, and patient discharged too without any neurological deficit. Everything is nice going. Yeah. The third case, it's a patient, 41 years old man. He's fallen from the height. You can see C6, C7 injury, our spine classification type C, and C has very hard neurological deficit, ASIA A, you can see in the photo, and the CT. You can see in the C6, C7 facet joint dislocation. It's a very difficult fracture. And I decided to do in this case 360 stabilization. Okay, you can see in CT. Okay, and CT after operation, I performed a laminectomy C6, C7. I put screw C6 in the lateral mass and C7 put in the pedicle. Transpedicular stabilization, and go to anterior, put a cage and anterior plate. From this you can see in the C6 and how it's look, and C7 how it's staying. Okay, and after surgery, patient to discharge to rehabilitation. And it's a very difficult patient, and a lot of time to he stay in ICU. Yeah, and 4 cases, and it's patient 36-year-old man. He is injuries when he is water diving. You can see C7 Th1 injury, our spine classification type C, ASIA B. You can see the dislocation, facet joint dislocation. In the CT after operation, you can see in the photo in the transpedicular screw in the C7, it a T1 I performed laminectomy C7 T1, and put screw transpedicular, firstly transpedicular C7 Th1, and after we go to anterior and put the cage and anterior plate. Look where is stability. How it's you can see how it's put C7, C7 and T1 T1 transpedicular. Yeah, and the last case, my case, it's 49 years old man falling from the height. You can see C6, C7 injury. Our spine classification type C, Asia C. It's CT before operation. You can see the lateral mass facet joint dislocation. It's a very difficult fracture too. I decided in this case do 360 stabilization. It's how I put screw in the C6 in the lateral mass and put C7 in the pedicular screw, and I go anterior, put a cage, and I put a screw on the C6 C7 body, and then I put anterior plate. It's video first of all from how it's look in CT. And how the axle video, C6 you can see screw, and anterior and C7 transpedicular. I put the screw. Yeah, this very stability, and after 2 months patient come to department, and how he is going. He almost recovery after 2 months. It's very nice result. How he show how it's in move inside my department. Yeah, it's almost recovery. And it's my last case. And for conclusion, for my opinion, 360 stabilization for cervical spine fracture provided the highest level of the biomechanical stability, superior control of production, and increased likelihood of successful fusion, making the optimal approach for several multi-component and instability injuries. And I would like to say thank you, Okukato, because in the March I have a nice fellowship on the Bantan Hospital. It's for me, it's a very nice experience. I saw a lot of nice surgery. It's very kind colleagues from Japan. It's a very beautiful months I spent in Japan. Thank you, Professor. That's all. My thank you, guys.
Thank you, Dr. Volodymyr, for great lecture. It's really impressive technique. I'm sorry, I seldom operate spine surgery, so I learn a lot from your lecture. So I cannot ask appropriate questions, and so just one question. What is most important for spine surgery?
I think most important for the spine surgery is stability and good fusion. Because it's very, very important, because if you not achieve a fusion, it's in the future you have a problem. You can instability, you need to do revision surgery, and sometimes it's a big problem.
Thank you. So we are starting discussions. Dr. Morisako, please.
Yes, so thank you for your thoughtful lecture. So I'm not a spine surgery, so but I have some question of your procedure. So how about the detail of the procedure? At first, you fix the posterior side or anterior side. So the sometimes first you usually decompress the posterior column of the spine, cervical spine.
Okay.
And
Thank you for your
at the fix and and so I'd like to know your strategy of the 30 degrees strategy. Yeah.
Thank you for your question. Yes, all time I guess I first go posterior. Because you see the facet joint dislocation need to this problem need to go into the facet dislocation and decompress and put screw, and after I go anterior. Only this way.
And the first stage, a single stage. At the same
sorry?
time, you usually perform at the same time.
The same time. We put we rotate in the operation room.
Thank you for your comment.
Next, Dr. Mao Yokota, do you have any question?
Thank you. Thank you. Thank you for your presentation. I have one question. So sometimes in Japan, we perform the VA embolization before surgery. How about you?
No, sorry, what embolization? I'm sorry.
VA embolization with endovascular.
No, we don't. Okay, no, we don't do. We go to we sometimes if patient don't have the neurological deficit, we use neuromonitoring if we need, and not embolization. No, we don't do this.
Thank you.
Thank you for your question.
Dr. Ben, do you have any questions?
Yes. And although I'm not very specialized in spine, but I do have some questions for you. I would like to ask about, in your case, do you always do it with a 360-degree stabilization? Because I saw some surgeon, because sometimes, for example, for some dislocation and facet dislocation, and some can be reduced with via the posterior approach and then followed by the fixation. And then some will only do the posterior approach. And I would either ask about your opinion. So would you always do the 360, or sometimes you do only posterior, or sometimes only anterior? So this is my first question. My second question is about in your center. So what is the protocol to handle the vascular injury, especially the vertebral artery injury? And during for example, in fracture, or sometimes inadvertent injury during the screw introduction.
Okay. Thank you for your question. Yes, it's very important. It's in this my case is when I saw the facet joint dislocation. I decided all of my case perform with 360 stabilization, because it's more stabilization. It's good for a patient because you stabilize all almost three column, and it's great fixation for my opinions. Yes, sometimes we going to anterior only when we don't have patient don't have facet joint dislocation. If patient don't have facet joint dislocation, we can go only anterior and fixation only anterior. About vertebral injury, vertebral artery form, actually I don't have opinion about this. For injury vertebral artery, and I don't tell you about this. Thank you. Thank you.
So,
Thank you so much.
Dr. Petra Wajopramano, thank you for coming.
Thank you,
Do you
Sensei.
have any questions?
Yes. Hello, Volodymyr. Long time no see.
Petra. Yeah.
I have one comment and one question for you.
Okay.
So my comment is for Ben's question. So Ben, Volodymyr said in the beginning he is using AO spine grade C classification for
Yeah.
all his cases. So that means there is a translation. Translation means all the three column, the anterior, posterior column is all disrupted. So he has to do 360 degrees. If it's just a grade B, for example, or a grade A, he can go anterior or he can go posterior. But see, now the recommendation from the AO spine is 360 degrees. So Volodymyr, that's a wonderful case selection there. It's perfect. All of it needs 360 stabilization. I have one question for you, Volodymyr. Do you routinely use MRI to assess these patients as well? Because sometimes we're not sure if there is a contusion or hematoma inside the dura before we open. I see you always decompress the bone posteriorly, but if you know with the MRI, then you can be more sure before doing your operation. How is your opinion?
Thank you, Petra. I'm very glad to see you again. For my these cases, yes, we only, because it's urgent case and we do only CT, and after that we go into operation room. Yes, sometimes this patient don't have very huge difficult neurological deficit. We can consider about performing MRI. But if patient has a huge neurological deficit, we go into operation room. Why we do laminectomy? Because if you can know if you put screw in the C7 and T1 it's very difficult because you can't do X-ray intra operation. We don't have arm. We don't have body and need to do, and I perform a laminectomy and put the screw in control in control in my eyes and put screw. So what is this reason why I perform a laminectomy? And it's laminectomy when a patient has a huge neurological deficit, I think it's better because after the patient has its edema, spinal cord edema, I think for recovery it's better for a patient.
Vladimir, so you use all the screw freehand? You don't use navigation? Okay,
yes.
because the post-op is so good. I thought you use navigation. Well done, well done.
No, without navigation.
Right. May I ask one question to Volodymyr? Volodymyr, you showed very number of cases, and this is one of the most common surgeries that we perform here. I would like to ask you, do you use a traction before the surgery? Do you keep the patient on cervical traction? And what is the weight that you put, if at all you use? And second question is, what is the sequence of events that you do in a 360-degree fusion? Like, is it the front first, then back, or back first, front, and go back? What is the sequence of events?
Okay. Yes, sometimes we use traction if it's dependent what it's a level fracture. For one level, we used 1/2 kilograms and put traction. But now we're trying to very fast go into the operation room and go into operation room and operation patient without traction. And how I said is the first all time we go posterior, and after we go anterior. To reduce the spine, reduce trying to reduce the spine. After we bite facet joint and put the screw and fixation, and go into anterior and fixation for anterior.
The problem with that technique is that when you have a facetal fracture, understood, you will not be able to reduce it.
Yeah,
so that is the question. So generally recommendation from the textbook is first you go anterior, do a discectomy. Okay, so that in case there is a ruptured disc, when you dislocate the original alignment, it may not cause harm. So first is anterior discectomy, go posterior, unlock the facet, come anterior, do a CDF, go posterior and put the screws. This is the classical description for 360, but nobody in practice generally applies this rule. So it differs in different centers. So what we do is usually go posteriorly first, reduce it, come anteriorly, do a discectomy, go behind, put the screws, then come anterior and fix it. That is the event. So it is a long surgery, takes a whole day. You have to turn the patient twice.
Turn the patient.
So that is very difficult.
Sometimes it happens. Yeah, need to rotation person a lot of time.
Fine. Thank you very much. So, Taka?
Are there any questions? No?
Not so
So
far.
let's go ahead the next session.
Yes,
Can I?
please.
Yes. So wait, I'd like to present one key point young neurosurgeon should learn. Can you see?
Yes.
So I still consider myself a young neurosurgeon, and it may be presumptuous of me to speak
Yes,
about
you are.
what the young neurosurgeon should learn. However, I'd like to be very pleased if I could share some of the work and approach we have been engaged in. We refer to surgery performed under the fluid filled environment, particularly using a rigid endoscope via cylinder or port as wet field surgery or technique. This concept may be familiar as technique used during hematoma evacuation, where the cavity is expanded with irrigation fluid to be better identify residual hematoma. It has also been reported as stereotactic cerebral underwater water aspiration scuba technique, like this. In practice, we have applied similar underwater environment to various regions, including cavernomas, cystic lesions, and intraventricular tumors. These are works of my mentors, both of them capilloma case. These are some tube retractors, several devices that relatively well described in lectures, and the literature are listed here. Among these, the system we primarily use is new robot series. This. We fix the endoscope using a scope holder, which allows us to perform bimanual manipulation. The figure below illustrates the position of the endoscope within the port, as well as the placement and the movement of suction tube and dissector. Three basic patterns of motion can be considered for the use of dissector. First, sliding motion along the port in which the dissector is advanced. Dissector is moved like this. The second, dissection using opening the closing the movement of forceps like this. Third, rotation manipulation of right angle dissector, like Fook dissector, in which dissection is achieved by pivoting the tip like this. These movements are combined with the motion of suction devices to perform effective and controlled dissection. The greatest advantage of wet field surgery as in hematoma evacuation is that the Operative cavity expands, allowing for improved visualizations of residual regions. As shown in this video, when operating under dry conditions during cavernous resection, the cavity tends to collapse and the visualization becomes obscured. However, upon irrigation, the visual field dramatically improves and cavity expands without the need for additional retraction. Additionally, hydrostatic pressure naturally contributes to hemostasis, particularly particularly for minor oozing. Although this is somewhat simple demonstration, or when water pressure is applied to bleeding surface, such as cut mouse model, bleeding is start, and the wet level is down, and up stops the bleeding, and down, and rebleeding is started. We have previously reported on this hemostatic effect of hydrostatic pressure. Furthermore, prolonged exposure of brain tissue to air may cause tissue damage, and wet field surgery is expected to significantly reduce this risk. On the other hand, my major limitation is that strong bleeding can easily obscure the visual field. In such a situation, it is necessary to increase irrigation pressure to identify the bleeding point or temporarily switch to dry field. Another limitation is lack of sufficiently compatible instruments that can be inserted through the narrow ports with minimal interference with endoscope. My mentors have been continuing efforts to develop such devices. And there is a potential concern regarding excessive pressure. Under normal conditions, when irrigation fluid is allowed to drain from the ports, the pressure applied should not exceed the height of the port. However, if there is any stenotic segment within the region that creates a check valve mechanism, pressure in deeper region may continue to rise. Therefore, it is essential to ensure that the volume of fluid introduced is adequately drained. Now, let me present a few cases. The first case is cavernoma, which was removed via transcervical port approach. As mentioned earlier, the wet field provided excellent cavity expansion and improved visualization. In the wet field, we can use forceps like this. Remove the lesions. After the removal tumor, this is very beautiful visualization. The second case is arachnoid cyst case. Underwater observation allows clear visualization of membrane bulking here, making it easy to identify the optimal site for fenestration. Moreover, the underwater environment may better approximate physiological conditions, facilitating the assessment of fluid flow. The third case is optic pathway glioma. We performed zeptostomy and partial removal in dry field, dissecting or dissecting from thymus. This is 45 endoscope, 45-degree endoscope. And after that, we introduce wet field, and after that, cyst fenestration with probe of navigation. We check the navigation image. We puncture the deeper cyst wall. So, although this has been somewhat brief and heterogeneous introduction, we aim to continue developing less invasive surgical techniques using this approach. I also hope that young neurosurgeon will take interest in this method and join us in advancing it further. Thank you. We should. So, anyone, are there anyone who have questions? Dr. Ishii, do you have any questions?
Professor Ishikawa, can I ask a question?
Yes.
Yes. And thank you so much. I like your technique so much. And I have some question about the wet field surgery, because I also tried it sometimes. When you do the hemostasis during the wet field surgery, do you use ordinary bipolar? Because if you are immersed in the water, sometimes it's hard for the bipolar to conduct the normal bipolar that we use in the craniotomy to conduct the electricities. So do you need to convert the wet field to the dry field for the hemostasis and then change it to the wet field? Or in your case, that your instruments is good to achieve the hemostasis under the water?
Thank you for questions. When bleeding, to some extent, irrigation power is much higher. That make hemostasis. But strong bleeding, we change to dry field and coagulated bipolar. But some bipolar system can good hemostasis in the under the water. We use Vesalius system. We can hemostasis in under the water.
I see. Thank you so much. And yeah, there's good case and good discussion about the underwater and the dry field to compare both techniques. Thank you so much.
Thank you. Dr. Petra Wajapram, do you have any questions?
Yes, hello, Taka-sensei. Thank you for the presentation. I have some comments because we are also trying endoscopic surgery a lot in our center. Sometimes in wet field surgery, we co-opt the radio frequency coagulation system from spine surgery, actually, because it works well in endoscopic spine. We reduce the settings and it can do coagulation for endoscopic intracerebral hematoma as well. Although it's a probe, it cannot pinch, so maybe the precision is a bit less. I have one question for you, Sensei. How do you regulate the water pressure for your wet field surgery? Do you use something that measure the pressure in real time, or please, your opinion?
No, we cannot measure the pressure intraoperatively, but the maximum pressure of the intra cavity is the highest port line. So we cannot measure the pressure.
Thank you, Sensei.
Thank you. The Dr. Biswas.
Yeah,
Sorry.
thank you, Sensei. It was an excellent presentation, a very new technique. Sensei, just two questions. What is the diameter of your endopore in this closed system? And considering you are utilizing 3 instruments through the endopore, I assume the diameter is a bit larger. So when you introduce interparenchymal, do you do initial transsulcal dissection, then introduce the endopore, or how do you introduce the endopore?
We use neuroport. Neuroport size is 2 size. One is 6.8 millimeter, and the other is 10 millimeter in diameter. And endoscope is inserted directly with scope holder.
Okay, well, you take the endoscope holder. Yeah. Okay.
Yes.
Thank
you.
And there is a question in the chat box and by Dr. Harsh, and his question is any endoport injury, and when you especially when you need to adjust the endoport, the direction, do you need will you cause some bring retraction injury?
If you move the port widely, the brain tissue may be damaged but we have not such damage cases. In our experience. And
great.
Thank you. The comment. Dr. Mama Dariev.
Yes. Can you hear me?
Yes.
Hi. Thank you so much for your presentation. I have a question related to endoscopic craniopharyngioma surgery. Maybe a question can be addressed both for Ishii Sensei and Taka Sensei, or you. So in case of endoscopic craniopharyngioma surgery, suprasellar mass, cystic lesion, and the solid is near the hypothalamus, and we try to remove the solid part of the craniopharyngioma. If we achieve it, but the remaining capsule of the craniopharyngioma is strictly adhered to the, for example, to the pituitary arteries and the hypothalamic structures, do you try to dissect the capsule, or just leaving it will be enough? And will it cause the recurrence, or how do you manage in these kind of cases?
If the cyst component is big, we cyst perforation operation is first performed, and 2 or 3 months months later, we removed by transsphenoidal surgery. We performed transsphenoidal surgery because cyst wall is shrink, and the dissection was performed naturally. In that,
so in most cases, after the fluid evacuation, the walls of the cyst can become easier to dissect, you mean, yeah?
Yes.
Okay, thank you.
先生も同じ意見ですか？
So if there is a tight adhesion between the cyst and the artery or nerve, I don't remove there. And if the cyst appeared after surgery, we choose the radiosurgery or something. So we don't remove total of the cyst, only safe part. I remove that.
Okay.
So
Reasonable.
mostly I choose the endoscopic endonasal surgery in craniopharyngiomas. Maybe Professor Morisako also choose the endonasal surgery, right?
Professor 先生いますか？
Yes.
Please,
So
please answer.
as the Professor Ishii mentioned, usually if the tumor capsule tightly adhere the vital structure, including some vital so important artery or the hypothalamus wall of the hypothalamus or the mammillary body, usually sometimes very difficult to dissect such a kind of the vital structure. So of course, sometimes we decide to intentionally remain some small piece of the tumor capsule. And at first, we usually follow up that small regional tumor capsule, and Professor Ishii mentioned, so that if some tumor capsule show the regrowth or we will plan the additional SRS or SRT.
Okay, very important tips. Thank you so much, senseis.
Thank
Dilshan,
you.
you have a gamma knife in your country?
Not yet. It was planning, but not yet established. We have neighboring countries like Kazakhstan having this equipment, so we can send to Kazakhstan maybe in case if we have remnants. Yeah.
Thank you.
And maybe any comment from Professor Prissett?
Okay. こんばんは。
こんばんは。
こんばんは。Salam alaikum.
はいはい。
Thank you very much. It's good and excellent webinar. And just for cervical spine trauma, I like to share our experience. We have also used freehand transpedicular fixation and also anterior approach. And unfortunately, we haven't C-arm and neuronavigation in Afghanistan, but we have excellent cases, and we would like to share our experience in the future with you. Thank you. Arigato.
Arigato. Thank you very much.
Thank you.
Thank you so much. So, any further comments from the audience? If not, shall we invite Professor Kato give some remarks on the webinar.
So I enjoyed all the speakers, the talk. Thank you very much. And also the nice comment from Morisawa Sensei and Dr. Petra. And also the Ishikawa Sensei presentation was so nice, I think. Misuwa Sensei, こんばんは。So I think in the future, because you're all young generation, so maybe you can have more innovate with some minimally invasive technique, I think. I enjoyed. Thank you so much.
Sensei, good to see you.
Hi, こんばんは.
Konbanwa.
Today is not in the car.
Yeah.
So just a little short. Maybe
Yes.
your endoscopic donation from the WFNS. So I think it may take a long time.
Okay.
So, any reason. So if not, maybe we can donate from Kato Foundation.
Sensei, one point can I share?
Hi, please.
Can I come in October, Sensei, if it is possible?
To my place. To where?
To Takijima Sensei and also at Bantane.
Takejima?
Yeah, to Takijima Sensei and also at your center.
Takizawa.
Yeah.
Takizawa Sensei is very seldom because we have so many endovascular cases.
Okay.
But anyway, please, October, you will come. Also, we have our biggest congress in Japan in October. Yes.
Okay. Thank you.
はい。石川先生、10月はいつでしたっけ、総会は。So October, we have the National Congress will be held, maybe I think late October.
12, 21 to 23,
yes,
maybe.
Yes, 3-4 days. Please, you can target during that time. Thank you very much.
Thank you.
Hi. About Sensei.
Okay.
So Dr. Ben, close.
Okay, so sure. And thank you so much for all of you to join the webinars today. And I know you have the biggest National Congress in Japan, but not to forget at the end of the October to the early November, we have also the World YNS Congress in Hong Kong. we are starting our registration and also the abstract registration. So we are planning on the workshop. We are opening it now, and more details are going to be confirmed. And keep an eye on that. So with that, I would like to thank our chair, Professor Ishikawa, and also for chairing the section of today and give her excellent one-point lectures. And also the two speakers of today and our friend, Professor Yudo Ishii, and also Dr. Volodymyr. And great to see you again. And also thank you to of our discussion, Professor Morisako and also Petra, for giving very nice discussions. And also thank you for the moderator today and to moderate the section with me, Roger, Neil, and Dushort and Mao, and also Bishwas. And thank you so much for joining us today on the ACNS webinar. So with that, I would like to close the section and I hope to see you soon personally. Thank you so much.
Thank you.